All right, well, next I want to talk about some tools for invasive airway management, specifically for intubation. And there's really two tools I want to talk about. And remember, the whole point of our emergency airway management is to oxygenate the patient first and foremost. That turns the emergency into the urgency. When they're oxygenated, you can back off, think a little bit, do the rest of what you need to do. You want to minimize the risk of aspiration and then get rid of excess carbon dioxide. So probably the most important tool, and it's being more and more recognized in emergency medicine, is the Bougie. Use of the Bougie every time, first pass, every time, increases success rates. That's been LifeFlight's experience, and there have been a number of articles published on that. So, Bougie every time. Now the next thing I want to talk about is videolaryngoscopy, and there's really two flavors. There's hyperangulated videolaryngoscopy, and there's what we would call a hybrid videolaryngoscope, direct laryngoscope, or videolaryngoscopy, direct laryngoscopy, or what are called normal geometry videolaryngoscopes. So what are all the differences? In direct laryngoscopy, you are looking at the cords. You are lifting up the mandible to align your three airway axes, and it is a linear passage of the tube. In standard geometry or VLDL hybrid, you are both looking at the cords directly, but you can also look at the video screen, which shows you the cords. You are again lifting to align. This is a standard intubation alignment anatomy, and it is a linear passage of the tube along the three axes. In hyperangulated videolaryngoscopy, all you're looking at is the video screen, because you are essentially sliding the blade around the anatomy and not lifting the mandible. Because of that, when you pass the tube, you are also curving around the structure. So you do not have the target in sight directly. Your target is only visualized on the screen. So there are advantages and disadvantages to all these approaches. Direct laryngoscopy, we all know it. It's how we learn to intubate. So that's one of its biggest advantages. However, in truly structurally abnormal airways, it can fail you. There are airways where, either because of anatomy or pathology, the vocal cords cannot be brought into view with three-axis alignment. Either you can't align the three axes, or even with alignment, there are still anatomical structures or pathologic structures in the way. For hybrid VLDL, you already know how to do it. It's just direct laryngoscopy, plus you can fine-tune your view at the glottic opening. So if you think about it like a backup camera, no one who knows how to back up just looks at the backup camera when they're backing up. They look behind them, they look in their side view mirrors, they look in their rear view mirrors. As they get close, they fine-tune with the backup camera. And that's essentially how a hybrid works. You do a standard direct laryngoscopy until you get to the level of the cords, and then you can do some incremental adjustment with the video. The downside to it is, just like direct laryngoscopy, it can fail in markedly structurally abnormal airways, either anatomically or pathologically. And the video cameras are vulnerable to ick. You get ick on your screen, you really have a hard time seeing. In the hyperangulated, you can navigate airways that are just, you wouldn't have believed you could see what you can see. And that ability makes it possible to essentially intubate any airway. However, this is different than what you're used to. If you don't do hyperangulated videolaryngoscopy on a regular basis, it is an entirely different sequence and action to do the intubation. And because it's a video camera, it's vulnerable to ick. Any questions? Just reach out to me. Thanks so much.